Hi, this is Piyush Bhargava, and I have a few interesting cases to share with you in this short video. Our first case is a 64-year-old female with history of metastatic ovarian cancer, a serous adenocarcinoma, who presents with rising CA-125. The previous value of this tumor marker was 17.5, and the current value is 50.7, and that triggered a whole body FDG PET-CT scan. We are looking at the whole body image on the left, and on this whole body rotating image we find physiologic distribution of the tracer and multiple foci of increased uptake in the lower abdomen corresponding to retroperitoneal paraaortic lymph nodes. One of these lymph nodes is shown here. The aorta shows atherosclerotic calcifications and there is intense FDG activity. Let's look at the rotating image one more time. Notice that there is no uptake and excretion of F18-FDG from the left kidney. And that is because the left kidney is hydronephrotic, that we see here, with very thin cortex, dilated collecting system, and then the ureter is obstructed by this retroperitoneal lymphadenopathy in the lower abdomen. So always pay attention to the kidneys and be aware of the manifestations of obstruction on the CT scan. The point of this case was actually tumor markers. So let's review some common tumor markers in radiology. Prostate-specific antigen for prostate cancer, CA-125, like we saw in this case for ovarian cancer. CEA, which is carcinoembryonic antigen for colorectal cancer. CA-19-9 for pancreatic cancer and cholangiocarcinoma. Alpha-fetoprotein for hepatocellular carcinoma. And chromogranin A for neuroendocrine tumors. This article is a good review of commonly used serum tumor markers. If you come across a cross-sectional imaging study, CT, MR, or FDG PET, for one of these tumors which has a tumor marker, and you do not look at what is the trend of the tumor marker, then you are doing a disservice to your patient, because sooner or later there will be a case where you will say that there is progression, but in fact you were wrong, and there's actually pseudo-progression or flare phenomena, and you made that mistake because you did not look at the trending of the tumor marker. So always remember to look at the trend of the tumor marker in any cancer patient for which there is a tumor marker that we can follow. The next case is a 58-year-old male recently diagnosed with esophageal cancer, and this patient underwent a whole body FDG PET-CT study, and we are looking at those images. Let's review the rotating image. And we see focus of intense hypermetabolism in the lower esophagus, that's their primary, and we see some small foci of increased uptake higher up in the chest. And so the primary is shown here, focal hypermetabolism in the lower esophagus, and metastatic disease in a small sub-centimeter paratracheal lymph node is shown here on these cross-sectional images. So remember, for esophageal cancer, the diagnosis and the staging of regional lymph nodes is made by endoscopic ultrasound and ultrasound guided biopsy. FDG PET does not do very well in that situation. The sensitivity of FDG PET is low, the specificity is high, such as here. If this patient had a diagnostic CT, we would have said, okay, these are sub-centimeter lymph nodes, probably not involved. But since there is focal FDG uptake, we are very sure that these are metastatic lymph nodes. The real value of FDG PET in esophageal cancer is when we are looking for metastatic disease. And this is a good article on that topic, the role of imaging in esophageal cancer management. Our next case is a 59-year-old female with history of lymphoma, and she had a whole body FDG PET-CT scan, which we will look at. Here's the rotating image. And this image shows a residual focus of hypermetabolism in the chest. This corresponds to a precarinal lymph node that we see here on the CT with hypermetabolism. Now let's look at the rotating image again and pay attention to the anterior abdominal wall. There are multiple foci of increased uptake in the anterior abdominal wall in the subcutaneous location, and these are being localized here on the CT. We see that these are soft tissue density with fat stranding. They're located in the subcutaneous anterior lower abdominal wall, and they're in a symmetric distribution, and they also show hypermetabolism. And so this is a common artifact that we see. This is FDG uptake in inflammation from injection granulomas. Patients who inject Lovenox in the subcutaneous space frequently get these artifacts where low venox can lead to fat necrosis. Necrosis leads to inflammation, and then we have FDG uptake. This is a very good radiographics article on imaging of abdominal wall masses, mass-like lesions, and diffuse processes, and it describes the CT appearance of injection granulomas. Thank you for watching.